Good afternoon, everyone, and good morning to those who are joining us from the West Coast. Welcome to today's webinar, Lambert Eaton Myasthenic Syndrome. We're really grateful to have Dr. Mike Nicolle and Dr. Hans Katzberg here today. Both are neuromuscular specialists. Dr. Nicolle is at the University of Western Ontario and Dr. Katzberg at the University Health Network. Both are, as I mentioned, neurologists who specialize in neuromuscular disease and have contributed to research in the field of myasthenia gravis. We're here today to discuss LEMS, and I'll pass it over to both of you. And once again, thank you for agreeing to give this talk.
Hello, everyone. My name is Hans Katzberg, and just a little orientation. We're going to do this didactic portion of the talk together, Dr. Nicolle and I. So we'll kind of do a back and forth, and then we're actually going to have quite a lot of time for questions and interaction. We do know there is patients as well as trainees and colleagues on the call today, so it will be a broad run through LEMS, but we're also some more specific queries, and we're happy to take the questions as they come afterwards. Mike, would you like to say anything before we get started?
No, I don't think so.
All right, welcome everyone. So here are the objectives for today. We're going to talk about the clinical characteristics of LEMS. I'll start with a case and a little bit on the pathophysiology leading into the clinical features. We'll talk a little bit about electrophysiology, which is critical, a little bit about serology as well. And we're going to try to distinguish LEMS, Lambert Eaton Myasthenic Syndrome, from myasthenia gravis, and then talk a little bit about management and some other special topics related to management that are of more recent interest. Here are our disclosures. So I'll start with a case which is from the literature, but I thought it was nicely representative with some features that may not be common to all LEMS patients, but I think it serves to highlight some of the important points. So this is an actual image from the case report presented, a male patient, 33, presenting with gradually progressive weakness of the right leg for 9 months, first around the hip area, so proximally to distal, and then also affecting the knee, ankle, and foot muscles around those joints. And then a few months later, similar presentation in the left leg and then in the arms. So one thing to highlight there is, as Dr. Nicolle also will highlight, is to note the kind of the ascending features of this rather than what you see in myasthenia, perhaps, which might be more of a top-down descending pattern. Similarly, in other conditions like botulism, you have a lot more ocular and bulbar type presentations early on. This particular patient's had thinning of muscles and atrophy and some other manifestations which correlated with proximal leg weakness early, like getting up from a squatting position. The only past history in this young man was past history of chewing tobacco, which I think is relevant, as you'll see, because of the association with cancer, so particularly lung cancer. So I think that is of relevance here, but otherwise healthy. Additional symptoms included early difficulty swallowing, nasal regurgitation, constipation, severe constipation, weight loss, and then in particular, when you see rapidly progressive kind of leg weakness, I think the lack of sensory symptoms is critical to distinguish it from other neuropathies or myelopathies. Visual complaints, that includes double vision, which I think would be of more relevance, and as you'll see later, perhaps early on in something like myasthenia, but certainly you can get ocular symptoms in LEMS, and Dr. Nicolle will talk a little bit about some of the subtleties to the presentation. The examination itself, the patient was cachectic, no postural drop in blood pressure, which again has relevance. You heard about the constipation, but which could be an autonomic feature. We'll hear about the prominence of autonomic features in LEMS, which is quite unique to LEMS versus myasthenia, where you do not see those autonomic abnormalities. The patient also did, at the time of the exam, show more symptoms than just the leg weakness, which was the presentation, which included bifacial weakness, reduced palatal movements, gag reflex that was reduced, but no tongue involvement and no extraocular muscle abnormalities. And of note, in this particular patient, there's no comment about ptosis, which can be a sign that you can see in LEMS. No fasciculation seen in the context of so much atrophy. Of course, you think about motor neuron disease or ALS, but the lack of fasciculations would be atypical for that. And here, as contrast to ALS, where you might have exaggerated reflexes, all the reflexes were absent except the biceps reflexes, which was reduced. So certainly reduced reflexes is key here. You do not see that in myasthenia unless there's very rarely, unless there's very, very severe weakness. And here it's prominent in early feature. As we mentioned in the exam, there was no sensory abnormality, so the patient did not complain of numbness or tingling, and really not much to find on the examination there. No fatigability, so when we test the strength in myasthenia, we often want to see if repetitive motion or sustained activity against gravity will fatigue, and here that was not present. However, the baseline strength was reduced. So in the lower extremity, proximally was 2 out of 5. And for those not familiar with this is inability to lift the limbs against gravity. And in the upper extremities, 3 out of 5. So there was some movement against gravity, but really no resistance, which is 3 out of 5. And 4 out of 5 distally in the ankle level means you can give some resistance. And again, we're jumping ahead, trying to put it all together in this case presentation, and we'll parse it out a little more in the subsequent slides. But the important tests here are electrophysiology. If we do routine nerve testing here, you may not see much on an EMG or on the nerve conduction studies routinely done, motor and sensory, but repetitive nerve stimulation here can show decrement, which suggests a neuromuscular junction abnormality. You can also see increment in the context of low amplitudes, which you can see here. And that can be highlighted with more frequent stimulation. Dr. Nicolle will go over what that looks like, or with 10 seconds of exercise in order to improve that connection between the nerve and muscle at the junction. So this is already looking like a neuromuscular junction abnormality in this case. And importantly here, although there was prominent weight loss, and in this particular case, I would strongly recommend ongoing surveillance, but according to this scan, the scans, CT chest did not show a tumor, and there was no calcium channel antibodies. These are the antibodies of relevance here, and that'll bring up a conversation about how often we find these antibodies, which is actually quite common. So certainly there's a number of atypical cases to this case, and aspects to this case. In this particular case, they did undergo treatment and improve significantly. So I think in the end, their conclusion was that this was Lambert Eaton Myasthenic Syndrome, but I thought it serves to highlight some of the important points. Just before Dr. Nicolle goes into the specifics here, this is what we're dealing with when we're dealing with Lambert Eaton Myasthenic Syndrome, really talking about a release of acetylcholine. These are these molecules that release from the presynaptic nerve terminal here, and then arrive at the postsynaptic membrane in order to create a end plate potential, which can then cause muscle contraction. And this this actual release of acetylcholine is mediated by calcium influx that you can see here. And if there is disruption in the calcium influx from something like antibodies to these calcium channel antibodies, then this will prevent the efflux of these molecules. So this is how you get LEMS, and we'll talk a little bit about how you can then help repair some of that abnormality. But this is a presynaptic abnormality in contrast to myasthenia gravis, where you have the antibody target against the postsynaptic proteins and channels here, which prevent the arrival and docking and then subsequent end plate potential from the acetylcholine. So the postsynaptic is myasthenia, presynaptic is LEMS, to summarize. So here's another just graphical representation in more simple terms, where myasthenia, as you can see here, is antibodies against this postsynaptic, and LEMS is against the calcium channels, which prevents the acetylcholine from being released. And I like this diagram. It's something drawn by my colleague in emergency medicine. Actually, we've done a couple of sessions on emergency neurology in the past, so I thought it was a nice thing to share, manifesting that previous diagram. Of course, there's other neuromuscular junction diseases like botulism and other toxicities, but today we're talking about LEMS there, which you can see. So with that, I will Just say one more word about antibodies and turn it over to Dr. Nicolle. So as I mentioned, these voltage-gated calcium channels are involved in the pathogenesis. PQ type calcium channel antibodies, so IgG against that is the majority, 85% of the abnormality causes this impaired release of acetylcholine. There's some other antibodies to other types of calcium channels that are also implicated, often coexisting with this PQ type calcium channel. And this is how you link it to small cell lung cancers, as you can have this calcium channel expression occurring on small cell lung tumors. So it's the same as molecular mimicry, where you have antibody targets against proteins that are expressed in different tissues, one in a pathologic tissue and then a bystander effect on our own healthy muscles. You can see the autonomic changes as well by the blockade of cholinergic and adrenergic voltage-gated calcium channels. And although you often will see this antibody present, there is something called seronegative LEMS, which can occur much more rarely, 10 to 15% of cases, either because the antibodies don't get to the threshold or there may be other targets as well. So Mike, I'll turn it over to you and just let me know when you want me to switch slides.
Thanks, Hans. So we'll get back to some of the clinical features of the Lambert Eaton Myasthenic Syndrome, or LEMS. LEMS can come in two forms. One is as a primary autoimmune disease, and the second is as a paraneoplastic disorder, almost always associated with an underlying small cell cancer of the lung. When you look at prevalence, so if you take the last 100 patients that you've seen, the literature suggests that about 40 to 50% are primarily autoimmune, and the remaining patients, so 50 to 60%, are paraneoplastic. My approach to the investigations of patients with LEMS is that there's such a strong link with small cell cancer that even if you do find another malignancy, so I remember one case in particular, one of the first cases of LEMS that I saw, who had a lung mass and the biopsy showed an adenocarcinoma, but then at the time of autopsy, she had dual pathology. She also had an underlying small cell cancer of the lung. So in adults, the link is very strong with small cell and not with other malignancies. So if you do find another malignancy that's not small cell, I would keep looking. In children, LEMS is very rare, and the paraneoplastic form of LEMS is extremely rare, but it has been in the literature associated with neuroblastoma and some of the lymphoproliferative malignancies, so leukemia and lymphoma. When you look at incidence, so keep track of every patient that comes your way. In my experience, about 1 out of every 5 patients is primarily autoimmune, and the remaining 4 to 5 patients are paraneoplastic. So how do you shift from 80% paraneoplastic in an incidence study down to 50 or 60% in a prevalent study? And I think the reason for that is that unfortunately patients with small cell don't last long enough to be counted in prevalent studies, because the 5-year mortality is less than, or 5-year survival rate is less than 5%. So many patients don't last more than a year or two. We know that paraneoplastic LEMS is probably underrepresented or underrecognized. As I'll talk about a little bit later on, there have been studies done that show that about 3% of patients with small cell will have positive anti-voltage gated calcium channel antibodies, and some of them will have LEMS. But I'm certainly not seeing that many patients associated with small cell, and I suspect many of them get missed and their symptoms get attributed to the side effects of chemotherapy or the cachexia that's associated with having an underlying malignancy. And as Dr. Katzberg discussed, the pathophysiology is well worked out in LEMS. The most common antibody by far is an antibody against the PQ voltage-gated calcium channel. It's the same antibody no matter whether it's primary autoimmune or paraneoplastic. It's also important to recognize the overlap that occur both serologically and clinically between LEMS and other paraneoplastic disorders. So they can have LEMS, but they may also have subacute cerebellar degeneration or a sensory neuronopathy, and may have other paraneoplastic antibodies. So not only may they have antibodies against voltage-gated calcium channels, but they may also have antibodies against things like HU. LEMS is myasthenia is a rare disorder. LEMS is a very rare disorder. In my crude epidemiology, I see about 50 to 70 new myasthenics a year, and I see 1 or 2 new LEMS patients. So it's roughly 1/50th to 1/100th of the prevalence of myasthenia gravis. So I tried to come up with a rough figure based on the better delineated epidemiology of myasthenia gravis. And the prevalence of LEMS is somewhere roughly about 1 in 500,000. Next slide, please. So the easiest way to remember the clinical presentation of LEMS is to remember the 3 A's. And the first A is a soft A in the sense that it's weakness. It's not really apraxia in the sense that these patients don't have motor apraxia that you would normally see with a disorder of the central nervous system. But it's apraxia in the sense that they have subjective functional difficulties, which are often much greater than you would expect given what you find on the examination, where the findings can be very minimal. So patients may complain bitterly of leg weakness, but when you examine them, the strength is often normal or near normal. 2/3 of patients will have this weakness, usually leg weakness initially, but eventually about 95% of patients will have weakness. And the progression, as we'll discuss later on, is kind of the opposite of patients with myasthenia. So whereas myasthenia often starts with ocular symptoms and then bulbar symptoms and then arm and least commonly leg, in LEMS, the most common presentation is with difficulties walking. So they present with leg weakness, and then later on in the course of the disease, they may develop arm weakness, and then the other more typical manifestations that you would see in a patient with myasthenia, so including ocular and bulbar manifestations. I used to say LEMS never starts with ocular manifestations, and there was a paper about 15 years ago from a Dutch group that showed that if a patient presented with double vision or droopy eyelids, in their work, it was never LEMS, but I must say since then, I have had a single patient who presented with ocular manifestations only, and 4 years into the course of the disease, he remains restricted to ocular manifestations, but has very characteristic electrophysiology and has positive voltage-gated calcium channel antibodies. And then the other clinical pearl, which I think is overblown in terms of its importance, is that the weakness in myasthenia fatigues with repeated contraction, and it is said that the weakness in LEMS may improve with repeated contractions. So the clinical equivalent of increment or facilitation or potentiation that we'll talk about a little bit more when we talk about the electrophysiology. I must say I've not been impressed with that clinically. I think we're often biased. We're looking for this, and it's easy to find it when you're looking for it. But I think if you were presented with a patient with LEMS in a blinded fashion, you would be hard-pressed to detect that initial improvement on repeated contraction. The second A is areflexia or hyperreflexia. And I think if you find deep tendon reflexes on the usual scale that we use to evaluate them of 2+ or better, you can almost always rule out LEMS with a fair degree of certainty. So the reflexes in LEMS are almost always reduced or absent, and that happens over 90% of the time eventually. And then there's this clinical trick that you can do at the bedside where somebody has an absent knee jerk. You get them to contract their quadriceps for 10 seconds, maximal voluntary contraction, and about 40% of the time, the reflex will reappear after that 10 seconds of maximal voluntary contraction. The final A is for autonomic, and again, that distinguishes LEMS from myasthenia, where there is no autonomic involvement associated with myasthenia. And LEMS patients can have just about any autonomic involvement. You can have involvement of the parasympathetic, slightly more than sympathetic. Patients can describe a dry mouth, they can describe constipation, men can have erectile dysfunction, and patients can have postural hypotension. But just about any autonomic manifestation has been described. But the big ones are dry mouth and constipation, and that occurs in up to 75% of patients eventually. So if I could have the next slide, Hans. So as a pop quiz, I've mentioned these, but the 3 clinical differences between myasthenia and LEMS, I'll give everybody 10 or 15 seconds to think about that. I'm not going to put anybody on the spot by asking them. Okay, next slide. So as I discussed, the progression of the weakness is different in myasthenia versus LEMS. This is a very broad generalization, and there are many exceptions in myasthenia. But generally, myasthenic patients present with ocular manifestations, so double vision and droopy eyes. They develop bulbar manifestations. And then as the disease progresses, if it does, they may go on to develop a head drop, so axial involvement. They develop dyspnea, so respiratory involvement, arm weakness. And then the least frequent in my experience is leg weakness. That's not in myasthenia. That's not to say leg weakness doesn't happen in myasthenia, but in my experience, it's often not due to myasthenia, and it may be related to something else. There are exceptions, as I said, About 5% of patients with LEMS present with a limb girdle pattern, so they don't have any ocular or bulbar manifestations. The other differences between myasthenia and LEMS are that in myasthenia, the deep tendon reflexes are unaffected, so they're not reduced, and you don't get autonomic involvement. For LEMS, the progression is almost always legs first, and then later on arms and bulbar and ocular. As I said, very rarely do they have ocular manifestations of onset. That does happen in LEMS, but it's just later in the course of the disease. And it rarely starts with isolated double vision or ptosis. And in LEMS, the reflexes are often reduced or absent over 90% of the time. And of course, you do get autonomic involvement, as I just discussed. Next slide, please. So how do you diagnose LEMS? The biggest hurdle or barrier is to suspect it to begin with. It's a rare disease that most neurologists and even many neuromuscular neurologists don't see a lot of. But if you see somebody who has a pure motor disorder presenting with leg weakness and they're areflexic, then you should consider LEMS. About half of the time, in my experience, the diagnosis of LEMS is made in the EMG lab. I should go back on that initial point that it's a pure motor process unless they also have a coexistent paraneoplastic sensory neuronopathy, in which, usually associated with anti-Hu antibodies, in which case they may have sensory symptoms. So sometimes it's a bit confusing. And then in the EMG lab, we can often make the diagnosis or at least strongly suspect the diagnosis. There's a triad of abnormalities. First and foremost, the motor amplitudes, the compound muscle action potential amplitudes are often reduced at baseline, often significantly reduced, so less than 50% of your lower limit of normal. The most sensitive test to look, or nerve muscle pair to look for this is in the ulnar to ADM, which is a bit of a paradox given that patients usually present with leg weakness, and I don't know why the ulnar study is the most sensitive, but it is. So in our lab, the normal amplitude would be 7 millivolts or greater, and in LEMS patients, you're often getting results of 1 or 2 millivolts, so they're significantly reduced. The second finding is decrement, exactly the same as you would see in a patient with myasthenia. So with low frequency stimulation between 2 and 5 hertz, we use 3 hertz in our laboratory. So it's the same pattern of decrement that you see in myasthenia, except that the initial motor amplitude is reduced. And then finally, the most specific, although not necessarily sensitive, is the finding of increment, also referred as facilitation or potentiation. And you can see that under 2 situations. The first is high frequency stimulation, and the second is after a maximal voluntary contraction. High frequency stimulation, so stimulation between 20 and 50 hertz, we use 40 hertz in our laboratory, is uncomfortable. I don't know if anybody in the audience has ever had it done. I do. It's like putting your tongue on an electric fence. You get a bit of a jolt. It doesn't last very long, but it is uncomfortable. So whenever possible, we try not to do that. The only situations that I would do high frequency stimulation would be in a child who's unable to cooperate, or if you're working on a patient in the ICU that's unable to cooperate, in which case high frequency stimulation by default is really the only way that you're going to be able to look for increment. But just as good, several studies have shown, is after maximal voluntary contraction, you look for an increase in the motor amplitude. So the idea is, again, the most sensitive study is the ulnar to ADM. You do a baseline CMAP amplitude at rest, and then have them maximally contract for 10 seconds. And then within 10 seconds, you want to repeat that motor amplitude, and you're looking for increment of over 60%, which differentiates it from normal. But if you're getting increments over 100%, that's certainly much more suspicious in the correct clinical context that this is LEMS, although can sometimes be seen in myasthenia as well. If you see huge amounts of increments, so over 400%, that's virtually diagnostic, but I have a single patient with myasthenia that had over 400% increment and had positive AChR antibodies, but negative voltage-gated calcium channel antibodies. And that's one of the problems in the literature, is that patients, there's this circular logic, whereas if you have significant increment, it must be LEMS. And if the voltage-gated calcium channel antibodies are negative, then it's seronegative LEMS. And I suspect some of those patients actually have myasthenia gravis. The antibodies themselves are highly specific and very sensitive, so over 90% sensitive. And in the paraneoplastic form, some would argue that they're almost 100% sensitive. So if you get somebody that you think has LEMS whose voltage-gated calcium channel antibodies are negative, I think you need to think very carefully about the diagnosis. And they are very highly specific, with the exception of studies that have shown that patients with small cell can have antibodies against voltage-gated calcium channels, but may not have any clinical features of LEMS. And then, of course, the other important part of the diagnosis in all patients is to look for an underlying malignancy, specifically small cell cancer of the lung. Next slide. So these are pictures showing the electrophysiology. The left picture shows decrement at 3 Hertz. I didn't put a scale on there. This is a study of spinal accessory to trapezius, but you can assume that the initial motor aptitude was reduced. So the decrement is identical to that you would see in myasthenia, but the motor aptitude is reduced in LEMS, whereas it's not usually reduced in myasthenia. The middle slide, or B, is an example of pre and post maximal voluntary contraction of the ulnar nerve, recording from ADM, I believe. So you can see that at rest, the amplitude was 0.3 millivolts, and then after 10 seconds of maximal voluntary contraction, it went up to 4.8 millivolts. So a very significant degree of increment. And C shows a similar thing with less impressive increments, only doubled in this situation. Next slide. So the diagnosis of LEMS depends on the clinical recognition, depends on electrophysiology, and depends on the demonstration of positive voltage-gated calcium channel antibodies. As I said earlier, you can get positive VGCC antibodies if you have small cell, even without LEMS. I'm certainly not seeing that many patients. You would expect, given the number of patients who have small cell, that if 3% of them have LEMS or who have antibodies against the voltage-gated calcium channel, that we should be seeing more patients with LEMS, and I'm not. So I suspect that they're often missed, and the weakness is attributed, as I said earlier, to cachexia, to the adverse effects of chemotherapy, and any number of other difficulties that patients with malignancies can get into. Next slide. So another pop quiz question, what's the mechanism of 3,4-diaminopyridine, or amifampridine is the new terminology for the medication that we use to treat LEMS symptomatically. And there are 2 brand names, both Firdapse and Resurgi. Both, as far as I know, have a similar mechanism of action. Amifampridine inhibits voltage-gated potassium channels. So normally, to repolarize a nerve, you need potassium to flow out of the nerve, and amifampridine blocks that, so it keeps the nerve in a state of sustained depolarization. So you get more bang for your buck. When the nerve depolarizes as the result of activation of the central nervous system, you don't get a single discharge, you may get multiple discharges from that nerve, and that increases the release of acetylcholine from the neuromuscular junction. So this is a schematic diagram similar to what Dr. Katzberg showed earlier, showing the presynaptic nerve terminal filled with vesicles that contain acetylcholine, and they rely on calcium influx through the voltage-gated calcium channels in order to migrate and fuse with the presynaptic nerve terminal and release acetylcholine into the neuromuscular junction, and it then binds to the acetylcholine receptor. So that depends on calcium getting in through voltage-gated calcium channels, and you can see that if antibodies were to block that, calcium doesn't get in, the vesicles don't migrate or fuse with the presynaptic nerve terminal, and you have a reduced amount of acetylcholine that's released from the neuromuscular junction. And amifampridine, or 3,4-diaminopyridine, reverses that by inhibiting voltage-gated potassium channels, which then increases the depolarization of the nerve, increases influx of calcium into the nerve, and increases release of acetylcholine from the presynaptic nerve terminal. Next slide. So to briefly discuss the treatment options in LEMS, the most effective by far is amifampridine, or 3,4-diaminopyridine. In my experience, it's much more effective in LEMS than Mestinon is effective in myasthenia as a symptomatic treatment. And often it's the only treatment that we have available, because in patients who have an underlying malignancy, I'm usually very reluctant to put them on immunosuppression for fear that it may increase the likelihood that their underlying small cell will disseminate or metastasize. You can use pyridostigmine or Mestinon in LEMS. I find it less effective. There was a nice study done about 10 years ago where they did a 4x4, a 2x2 analysis, and they put patients on either placebo or Mestinon, and then in the other arm, they were either on placebo or amifampridine, 3,4-diaminopyridine. And what they showed in that small study, I think they used clinical and electrophysiological endpoints, was that Mestinon itself didn't do anything. And mestinon, in addition to amifampridine, was no better than amifampridine alone. So I would try mestinon, especially as it's going to take some time before you can get amifampridine, given the current approval process, at least in Ontario. I'm not sure what it's like in the rest of Canada. So you may as well try something. And I would say maybe a third to half of the time, patients with LEMS get some response to pyridostigmine, but it's often suboptimal. And then in patients who have the primary autoimmune form of LEMS, immunosuppression, as you would for myasthenia, is a mainstay of treatment. So I use IVIG in an acute situation or plasma exchange, so immunomodulation, but putting patients on prednisone or one of the steroid-sparing agents, mycophenolate and azathioprine would be the two that we use most commonly, is certainly an effective way to manage the disease beyond symptomatic treatment with amifampridine alone. Immunomodulation works in a pinch. So if you do have a patient with LEMS who has significant bulbar manifestations, dysphagia, or has respiratory involvement, then treatment with IVIG or Plex would expect it to rapidly improve the patient. And then there's some evidence that treatment of the underlying small cell may also improve the course of the LEMS. I'm not a huge fan of that hypothesis, because when you look at what we actually do when we treat small cell, it's actually a very potent form of immunosuppression. So these patients go on chemotherapy, which is often toxic to the bone marrow, so it results in intrinsic immunosuppression. So you're not really not treating the disease, you are treating the LEMS by immunosuppressing them. Next slide.
So I think I was going to present the rest of the slides from here, Mike.
Great, thanks, Hans.
All right, so I thought I would just to follow up on Dr. Nicolle's discussion on treatment, referencing this recent review. My colleague, Dr. Vera Brill and Dr. Jean Verschuren from Holland put this together, both on myasthenia and Lambert-Eaton. And you can see the flowchart here is very similar in that you want to be sure about tumor. Of course, thymoma in myasthenia, but small cell lung cancer in Lambert-Eaton Myasthenic Syndrome as the primary thing. Although, as Dr. Nicolle said, it may not treat the disease. It's certainly something you want to identify early on if you're the first person encountering this kind of presentation. And the next level, as we do in myasthenia, often being the symptomatic treatment. And it's particularly important in LEMS to help control the symptoms, and perhaps even more effective than in myasthenia to control symptoms. We often have to use more than just mestinon in myasthenia, which can have more severe symptoms. And certainly that is also the case in the LEMS, but often you can get quite a robust effect in LEMS, and you may not have as many crises or involvement of bulbar, although in the case you saw, you may see that, but certainly symptomatic therapy is still frontline. And if you don't get enough effect from that, then as Dr. Nicolle said, we often will use the immunosuppression, and that mimics MG. So that's why there's commonality in the end part of this flowchart, where you can use corticosteroids, steroid-sparing agents, either one or an alternate if the first doesn't work. And then, of course, step up immunotherapy. Again, here the options may be more limited, as there are now new available biologic agents such as complement therapy that has been tried in myasthenia, acetylcholine receptor antibody positive myasthenia. So in LEMS, really you may be more limited using the steroids, steroid-sparing agents, and IVIG and plasmapheresis. Another interesting point about LEMS in cancer. So one thing you might try to determine early on is if you're the first person encountering and diagnosing LEMS, is what are the chances that there will be cancer. And there is a scale that's been developed, Dutch English Lambert Eaton Myasthenic Syndrome Tumor Association Prediction Score, a delta P score. And as you can see, some of the features associated with the acronym. So you have the DELTAP. So D standing for dysarthria, dysphagia. So if you do have bulbar symptoms, that would score you a point. Erectile dysfunction as an autonomic feature. Weight loss more or less than 5%. Tobacco use at onset. Age, being over 50, giving you a higher point. And then Karnofsky performance score, basically a measure of just overall wellness. If you have a lower score, or rather a higher score indicating a lower score indicating lower reserves, that may be a higher risk. So with the scores of 4 or greater, this is a greater than 90% chance of tumor development. So, my impression of the case I presented is this person actually would be quite at high risk. So even though they did not find a small cell lung tumor on the initial scan, that you would want to continue looking, perhaps with PET scans or with other methods, because that patient may have been at a higher risk of tumor development. Whereas if they had less points, this might be less. So the main features here that were independent predictors: weight loss, tobacco use, and age over 50. Just a couple of points about the evidence for immunosuppression or immunomodulation. So IVIG was mentioned. So this is a review about IVIG use in neuromuscular disorders. And there is a class 2 placebo study, a small study in 10 patients that showed a modest benefit on limb strength, drinking time, antibody titer, and vital capacity in LEMS. So based on that, this is a class 2 study, was labeled in terms of the level of evidence, was determined that IVIG was possibly effective and determined to be level C. So it's not uncommon that if you have lower levels of evidence, so you'll have a lower grading for recommendations, but certainly something that I think can be considered, particularly if someone's presenting more acutely or with concerning symptoms. I think IVIG can be helpful. And similarly, plasmapheresis, again, although it's not category 1, it is listed as a category 2 option for patients with more active LEMS. So again, same limitation in evidence, but still a good option if someone's presenting more acutely. And then finally, I just wanted to touch base on a couple of studies that are more recent. There was a comment on what research has been active in LEMS. So here's a study from Europe, 30 centers. So I think the other reason this is useful is because it's not that common to have a large group of LEMS patients where we can kind of make some assessments of commonalities and clinical features. As Dr. Nicolle mentioned, it's quite a rare disease. So if you pool a number of different centers, you get up to 96 patients with LEMS. Most of them were treated with the 3,4-diaminopyridine. And I think the other point to this study is that you notice here the 3,4-diaminopyridine drug, and some of these were mentioned earlier that are available and formulated. But there's also a compounding that can be done for this medicine in Europe, at least, it's available. And there's some discussions about whether that is helpful or useful or safe. So that was the other impetus for this study. And you can see many patients were treated with that formulation in addition to the proprietary commercial product, and also about a third of them treated with immunosuppression. Most patients had ataxia. So as Dr. Nicolle mentioned, you may not identify the weakness on exam right at the outset. So this leads to this unusual gait, the apraxia in the lower extremity abnormality that often leads to abnormal ambulation. Most had hyperreflexia and limited functioning. All 3 treatments resulted in sustained or improved functioning. So really similar amongst the 3 groups of patients: immunosuppression, 3,4-DAP, and 3,4-DAP phosphate, with no new major safety signals, and about a third of patients experience adverse events. In Japan, they had an estimate of prevalence about 2.7 in a million. About half patients had a tumor in their population, most of them small cell lung tumors, predominance of men in patients with tumor, and of women in patients without tumor. Age of onset about 61, and in the autoimmune form, slightly less than 67, so at 57. And medium duration of disease for the paraneoplastic form, 2 years, and for the autoimmune form longer, as you might expect. Someone with tumor presenting more acute actively. So again, this is just experience from a national group that again kind of really highlights some of the points that we were already mentioning, some recent reports that helps to consolidate what we know. I think this is not specific to LEMS, but I just, LEMS was included. So just something that those with myasthenia are well aware of, what to do during a pandemic. And I think it's just basic principles on continuing your current therapy. There's really no evidence that the 3,4-diaminopyridine or other similar symptomatic therapies increase risk of COVID infection, which is kind of intuitive. Maintain vigilance, try to minimize the blood work in the high peaks of infection if not needed. Reconsider B-cell therapy. Again, that's not really a strong consideration in LEMS early on in particular, but that was a bit of a concern about the level of immune suppression that one would get. And then in mild, the other issue that comes up is what if someone gets COVID and is on immune suppression or immune modulation? And again, that's a case-by-case basis, as it is with myasthenia and LEMS, where you really want to maintain the immune therapy if you can, unless it's really very unsafe for the patient, and the treatment needs to be held or changed in any way. So hopefully we don't encounter this to a great degree, but I thought just important to highlight. And then finally, something very topical is that of checkpoint inhibitors, because there's checkpoint inhibitor myasthenia and myositis, a lot of immune syndromes. And because small cell lung cancers are being considered for different immunotherapies, the question has come up whether these drugs can worsen the LEMS, for example. And although there was a number of case studies and case reports, about 90 or so in the literature, this systematic review really did not find a high level of strong evidence linking the two, and really recommended more vigilance, further work in this area, larger scale studies. But certainly the concern is there as more new biologics are available for cancer. So I thought that was something useful to highlight as well. So with that, we will stop, and hopefully that will leave enough time for questions.
Thank you both for a really clearly and well-delivered presentation. There are a few questions that have already come in, so if it's okay, I'll go ahead and just read out the question, and whoever would like can respond. This individual is sharing that they do have a patient with LEMS, no evidence of cancer at the initial workup, and positive SOX1 antibodies. What would the follow-up schedule look like? What would be the recommended follow-up schedule for a patient like this?
So
I
Mike,
I do, and then Dr. Katzberg can tell you the right way to do it. I investigate all patients, even though I don't think that they have an underlying malignancy. If you have a young woman who's a non-smoker and who may have a second or third autoimmune disease, it's probably going to be primarily autoimmune LEMS. But I still do a CT scan of the chest. I repeat the CT scan every 6 months for the first 2 years. And then for the next 3 years, I do it annually. So you do serial CT scans for 5 years. If I have a very strong suspicion that they have LEMS, as Dr. Katzberg mentioned earlier, I will get a PET scan to make sure that we're not missing a very early LEMS, because if you can discover it earlier, in theory, you can improve the outlook. I've even had the respirologist go in and bronchoscope somebody that I was very convinced had a paraneoplastic form of LEMS, because they've been losing weight, even though the initial CT scan was normal or negative. And the yield for that is high enough that it's worthwhile. The one case I remember very distinctly was a woman who I was pretty sure was going to have an underlying malignancy because she was a smoker and had been losing weight. The initial CT of the chest looked fine, and then 3 months later, the CT scan showed a very large hilar mass. So sometimes it can progress very rapidly. So I think that's what I do. Hans, do you use a different approach?
No, very similar. I guess the thing I didn't highlight in the slide on antibodies is that this SOX antibody has been also described. So, some of the seronegative to voltage-gated calcium that we mentioned could have other targets. So, but I agree, if there's no other major concerning features, it most likely is autoimmune, but I would do a similar schedule of chest CTs in someone who you are wondering about cancer. You can also perhaps use that score and also use close monitoring. But this certainly would be one where, not in this particular case, but if you are suspicious and there is a voltage-gated calcium channel, where I agree you would want to do PET scan, bronchoscopes. I remember, similar to other paraneoplastic syndrome, sometimes it's a small lymph node, that's all you got to go on in the chest to do the diagnosis, and that may be the only way to confirm the diagnosis. So similar to surveillance that we do in dermatomyositis or neurofibromatosis, it's important to be vigilant.
And I mean, it's worth pointing out that there are some retrospective studies that show that the prognosis from the small cell, which admittedly is poor, is better in the context of LEMS for two reasons. One is that the autoimmune process that's causing the LEMS is also attacking the calcium channels on the surface of the small cells, so that it may actually produce more limited disease. And the second reason is that by virtue of the fact that they present with LEMS, you're looking for a small cell, so you're more likely to discover it at an earlier stage of the disease. So it is worthwhile looking early on, as you may improve the patient's outlook from the underlying small cell.
Very good, thank you. This question is, are there any new diagnostic biomarkers or imaging modalities that are promising for the early detection of LEMS? Anything that is emerging evidence there?
Not that I'm aware of.
Oh, I don't know of any. I think that this is the one condition, I think, where electrophysiology is very useful and helpful. Can be a tough clinical diagnosis sometimes because the patient's coming in has not much to find on objective exam and some unusual gait, maybe bilateral ptosis and autonomic features that you may not pick up right away. So I think electrophysiology is the mainstay. And the Mike, I don't know where you send the antibodies, but they're quite readily available. I think wherever you get your MG antibodies, we send them to UBC for voltage gated calcium. I don't know if you do them in-house, Mike.
No, we do them. We send them to UBC as well.
The next question here is whether resergy and guanidine, hopefully I'm saying that right, if that tends to happen, if you tend to prescribe that together, and if so, is there any benefit to doing so?
I have never used guanidine.
No, I'm not aware of any literature on that.
Very good. Is there evidence for treatments for LEMS to be as good in pediatrics as it is in adults? So they were noting that resergy is for those over the age of 6. I know you both work with adult patients, but is it as good or demonstrates as good benefits in pediatrics as it does in adults?
All I can talk is in theory. I've seen 1 or 2 pediatric cases, but they were, late teenagers, so they were almost adults. But in theory, they should respond just as well to amifampridine as an adult would.
I have some patients with congenital myasthenia where we've been using 3,4-diaminopyridine, and those are young transition patients, and they respond very well. Obviously, it's a different disease, but I agree. I don't think there's any reason to think they wouldn't respond the same way.
For those of your patients that are on treatment, what do they report to be the most obvious improvements? Do you see improvements in terms of dry mouth, or is it primarily more muscle function?
So I have an amusing story, a gentleman that I saw maybe 5 years ago with LEMS, and the most common or obvious improvement is in their leg weakness, but this man was much more excited that his erectile dysfunction had improved after treatment with amifampridine. So amifampridine, because it works, irrespective of whether it's at the neuromuscular junction or whether it's at an autonomic synapse, will improve not only their motor weakness, but will also improve their autonomic manifestations as well.
Yeah, I think that's also been my experience. And if you remember back to the pathophysiology slide, it's the same mechanism. The calcium channel targets not on the presynaptic nerve terminal, but on the autonomic nerve terminals of different types. So I think I agree, it works the same way.
So we do have a physiotherapist on the line who's asking about overexertion. Are you aware of whether this is an issue or something that they should be mindful of when discussing rehabilitation plans with patients?
The question about activity and exercise comes up a lot in neuromuscular diseases in general and myasthenia. I usually use the same kind of recommendations for most patients, which is that obviously everyone is different on their level of activity. You don't want to be completely sedentary, of course, because then you can develop atrophy and worse deconditioning and weakness. But it's all about the level of activity you can tolerate. And if you're wiped out the next day, that's too much, and you titrate from there. I think in this condition where there is potentiation that can happen, as Dr. Nicolle was alluding, but really it's not a practical, as you heard finding on exam, it's not a practical thing to use in terms of therapy. It's really the same concept, which is fatigue and weakness. So I think the same principles apply. Mike, do you have any additional
Yeah,
comments?
I agree. I basically use the rule of common sense that, as Dr. Katzberg said, if you do something and you're worse, don't do it or do less of it. But they're better off, as a myasthenic is, to do more frequent, brief, and less intense periods of exercise than they are if they decide to go out and run a marathon for the first time. So you want to use some common sense.
We do have some patients here on the line as well reporting that they were often given misdiagnoses before seeing a neuromuscular specialist, which I'm sure you both have seen as well. Would it be someone?
Can you
So
repeat,
Might have
Mara? You cut
had.
off. Yeah, I just cut off for a second.
I sure can. Hopefully you can hear me well, and I'll try something different. But the question is whether would it be common this individual received a diagnosis of limb-girdle muscular dystrophy? Would that be a common misdiagnosis in the case of LEMS?
Unfortunately, yes. Now, I'm not sure that I've seen a patient specifically diagnosed as having a limb-girdle muscular dystrophy, but they often come in with other diagnoses or without a diagnosis. I mean, LEMS is such a rare disorder that it's not top of the list for other physicians and non-neuromuscular neurologists to think of. As I said earlier, 50% of the time the diagnosis is made in the EMG lab, even though we may not suspect it clinically. A good EMG tech will recognize the pattern of diffusely reduced motor amplitudes and then go ahead and do pre and post maximal voluntary contraction.
Yeah, I think we often encounter, especially particularly in patients maybe who have not been seen for many years, and part of this might be just the access and availability of testing. It's not infrequent we'll see someone with a nerve disease or a junction disease that was labeled as muscular dystrophy years ago, and then re-diagnosed. Actually, we just saw someone last week who was diagnosed as a congenital myopathy, and it turns out they have a congenital myasthenic syndrome. So, we often will, have that umbrella term for a lot of our neuromuscular patients. That's why it's great that MDC is, highlighting neuromuscular junction disorders. There's a lot of commonalities. And as Dr. Nicolle said, it is a rare disease and a tricky disease. So I agree, it's not uncommon until you get to an EMG lab and accurately do those tests.
Final question here, and hopefully you can hear me okay. And the final question is, have either of you experienced access issues with the treatments that you've mentioned? One individual here is mentioning access issues with Resurgi, and the other is mentioning access issues with rituximab. They haven't listed which province they're practicing in, but any access issues for either of you for your patients?
Yes, I mean, cost is a major issue. There's a long history of this. The 3,4-diaminopyridine used to be provided relatively inexpensively from a company in New Jersey. And then two companies got into the action to compete for licensing rights, and they both ran their own clinical trials. And now they're both approved, but the price has gone up tenfold compared to what it used to be. I know that they're currently negotiating with the government and with the major insurance companies to get this covered. So hopefully the situation will improve over the next year. I'm told that as of October, at least in Ontario, they're going to have an agreement in place that we can get amifampridine using the special access program. So I think for the last 2 or 3 years, it's been difficult to get drug. You can get drug, but to get somebody to pay for it, because I think it's, Hans, you can correct me if I'm wrong, but it's upwards of $40,000 a year if you had to pay full price for amifampridine, and nobody can afford that. So, I have had patients that I simply couldn't get on drug because they couldn't afford it.
Yeah, I agree. It's a big issue and very discouraging, obviously, for patients and for the physicians. There's been many letters written advocating. There's been news articles that many of us have participated in, trying to highlight the access to medicines on a cost basis. Fortunately, there is some compassionate programs, particularly for LEMS now, and then hopefully a more formal program through the government. So I think I would, if the diagnosis is LEMS, I would really try to explore all the options, because there should be a way to access it even now through different programs until the government puts theirs in place. I think the other big challenge is for congenital myasthenia, because that is not approved. The trials were not run in that condition. So there I see even a bigger challenge. So I agree, there is issues, and a lot of them are cost related.
Well, thank you both, Dr. Katzberg, Dr. Nicolle, for a really clear and well-delivered presentation. We really appreciate your time and expertise. Wishing all of you who joined us for the webinar today a good rest of your day. Thanks, everyone.
Thank you. Thanks, everybody, for your attention.
Thank you.